I'm absolutely delighted to be hosting this webinar today. My name's Jo Bullingham. I'm the General Manager for the charity, and we're delighted to welcome Dr Jeffrey Boris, who's also joined by Dr Leslie Cavey, the Chair of PoTS UK. We haven't actually run webinars for a while. They kind of started in lockdown, and we've had a bit of a gap from them for the last year or so, but it's really great to have restarted them, and seems very appropriate as well that our first one restarted is on the 1st of October, the beginning of Dysautonomia Awareness Month, and a lovely way to kick things off. As you may have seen from our social media, or our newsletter or our website, we've got an absolute plethora of things going on during Awareness Month, and then for PoTS Awareness Day itself on the 25th of October. So we really hope that people can get involved. Please do check out what's going on and see what things you want to get involved with. We've got 31 ways that we've given ideas that you can do to help raise awareness during the month. So there's absolutely masses for people to get involved with, but I will leave that bit there now. So our webinar today is about PoTS and young people, and we're really grateful that Dr Boris has joined us to deliver a presentation which will be about 40 to 45 minutes, and then there'll be time for questions afterwards. If you pop your questions into the Q&A box, and then we'll pick those up at the end. As we always say, we can't answer specific specific questions, so it needs to be something that is able to, Dr Boris or Dr Cavey are able to answer. We won't be able to do it without everybody's medical history, so we can't be too specific in those instances. And if you think of anything after the webinar, or if you've got any questions or feedback, then please feel free to send a message to the trustees@potsuk.org email address. Would you both like to introduce yourselves before we start? So Dr Boris?
Certainly. So, Dr Cavey, do you introduce yourself then?
I can do. So I've been with the charity since just after it kicked off in 2010, and I am a retired GP, and I'm here to learn a little bit more about paediatric PoTS today, and also to help out with the Q&A at the end.
So I'm Dr. Jeff Boris. I'm a pediatric cardiologist. I've been practicing pediatric cardiology for 27 years now. And I am also a self-described pediatric autonomic specialist. I've been taking care of PoTS patients for 22 years now. I've seen probably over 1,200 patients with PoTS, and have published a fair bit of research in the field, and we'll be sharing some of that with you today as well. So
thank you so much. If you want to share your slides, then that would be fantastic. And we always get lots of people asking, will this recording be available afterwards? And it will do. It will be added to our YouTube channel within probably sooner than this, but definitely within a week of today. And what we'll do is, for everybody who's registered on Zoom, we will send an email out confirming once that recording is available. So without further ado, I'll hand over to you now, Dr Boris, but thank you again. And like I said, everyone, just please pop your questions in the Q&A box, and we'll have time for that at the end. Thank you very much.
And off we go. All right, so let's talk about PoTS. Oopsie, let's do that. There we go. Just quickly, there will be off-label uses mentioned. I am a paid consultant for a few different entities, and I'm on the Medical Advisory Board of Dysautonomia International. So what is PoTS? Well, PoTS is variable autonomic dysfunction. It's the most common severe dysautonomia as compared to pure autonomic failure, multiple system atrophy, the hereditary sensory autonomic neuropathies, etc. So what is a dysautonomia? Well, dysautonomia is a general term for dysfunction of the autonomic nervous system. So what's the autonomic nervous system? Well, that's the part of the nervous system that controls heart rate, blood pressure, GI motility, sweating, all the things that maintain normalcy in your body without you having to think about it. So postural orthostatic tachycardia syndrome, also known as chronic orthostatic intolerance, is probably associated with poor vascular tone and a compensatory tachycardic response. And that's sort of a simple way of talking about it, but we'll talk about other issues that go with it. The name first came in 1982 by Rosen and Cryer. However, it was likely first described in the medical literature as early as 1871 by Jacob DaCosta, who was a United States Civil War soldier or physician in Philadelphia, describing what happened to soldiers on the field after they got dysentery. They were quite worthless as soldiers. So what kind of symptoms do we see with this? Well, certainly we see severe dizziness. And we talk about dizziness, we talk about both lightheadedness as well as vertigo. And I think as time has gone on, I have certainly recognized in my practice that patients have lightheadedness, that feeling like you're going to pass out. But they also have vertigo, that feeling like the room is spinning, and that's a separate entity. Patients have tachycardia and palpitations, hypotension or hypertension, non-cardiac chest pain, intense fatigue, slept 10 hours last night, wake up, feel like I haven't slept at all. Heat intolerance and or cold intolerance. Brain fog, difficulty concentrating, difficulty remembering, difficulty thinking. Weakness, photophobia, so light bothers them. Phonophobia or hyperacusis, sound bothers them. Depression and anxiety, which is comorbid. It's not a cause of PoTS, but it certainly can occur with. Chronic pain, sleep disturbance, so insomnia, difficulty getting to sleep and or staying asleep. Headaches, especially migraine, but also tension headaches as well. Syncope, passing out. Nausea and throwing up. Bladder dysfunction, abdominal pain, exercise intolerance, GI dysmotility, so constipation, feeling full early, that kind of thing. Venous pooling or mottling, hands and feet turning purple, blotchy, swollen, red. The symptoms can occur worse with upright position, but they can certainly occur either supine or in the seated position. It's worse perimenstrual. We have some data that I will share later about that, where 72% of girls and women have worsening PoTS symptoms, typically in the 10 days prior to or the 5 days during their period. Symptoms are often worse in the morning. They're often worse with intercurrent infections. And the symptoms can be variable, so they can occur, they can change day to day, month to month. There's also this concept of the October slide, where for whatever reason, somewhere between mid-September and mid-November, at least what we see in pediatric patients, is their symptoms get worse for some reason. So why does this happen? I just don't know. I wish I did, but you know. In 2024, I think we're still quite clueless. I think we have noticed a few things that certainly can occur after an antecedent viral syndrome, Epstein-Barr virus, influenza, Lyme, SARS, the COVID infection, etc. Even after just a straight up upper respiratory tract infection or gastroenteritis. We can see this post-concussion or after other trauma or surgery. There are certainly associated inflammatory disorders with this: Sjogren's disease, lupus, eosinophilic esophagitis, mast cell activation syndrome, which is increasingly being recognized. They can also have joint hypermobility, seen with hypermobility spectrum disorder or hypermobile Ehlers-Danlos syndrome. We published some data that up to 61% of patients with PoTS have joint hypermobility. In my present practice now with over 200 patients, it's probably about 75%. We see this after rapid growth or hormonal change, also menarche or onset of menses. However, a lot of times it's just idiopathic, meaning we have no idea why this really started. We do see it happen in families. 14% of PoTS patients have a family member with PoTS. Could this be an autoimmune concept? And there have been several abnormal antibodies that have been found, but just their presence does not mean that it's the cause, right? We have seen that 45% of patients with PoTS have a family member with autoimmune disease, which is pretty high. So who gets this? Well, it is typically adolescent girls at a ratio of 4 to 5 to 1, but we do see it in boys. We can see this in kids younger than adolescents, and they're often very typically high achieving in academics, athletics, or both, which means it just feels like a much further distance to fall for these folks. So can't it just go away? Well, there have been several papers that have been published on long-term outcomes, and until our latest paper a couple of months ago, there was some thought that you could just outgrow it by adulthood. From a paper from the Mayo Clinic, about 19% of patients had, quote, outgrown it, another 65%, quote, improved, sort of. In the Mayo Clinic, they don't follow their patients longitudinally, right? So that gets to be problematic. And only 1/3 of their patients responded to the questionnaire. Interestingly, during stress or infection, their symptoms recurred. So in our survey of 227 patients, which we just published, we demonstrated that 99% of patients were still symptomatic in the month prior to filling out their survey. And that's with a mean duration of 9.6 years from onset of symptoms to the time that they filled out the survey. So we really think that PoTS doesn't go away. However, a large majority of patients were able to finish high school. The majority were able to work with accommodations, and we'll talk about that in a little bit. So what are the goals of managing PoTS? Well, certainly to manage, in my approach at least, is to manage the symptoms to allow these patients to be able to do their activities of daily living and to be able to exercise, because we know that chronic and progressive exercise helps to suppress symptoms more completely. So increasing exercise, we see what helps is a combination of aerobic activity as well as leg and core strengthening. Not sure why. Does it improve the muscle pump? Does it retrain the autonomic nervous system? Don't know. And as time goes on, hopefully we can reduce the need for supportive medications as their symptoms improve and their exercise increases. But, this is PoTS 1.0. And since we don't know the underlying pathophysiology, we're not treating the actual disorder. We think that it's probably, for a lot of patients, if not all of them, autoimmune or some sort of inflammation or some sort of something. Or maybe it's multiple paths to the same conclusion. I'm hoping within the next 10 to 20 years, we will have better research that will give us better insight into what is happening for these patients, so we can have more direct targets to help look to even cure this. So from a diagnostic standpoint, the history is most helpful. I mean, these patients have severe and debilitating symptoms. It's not just sort of typical symptoms of, oh, I stood up, I got a little head rush, I got a little bit lightheaded, and then I'm fine. And I can go about my day and just do whatever I need to do. On physical examination, we see evidence of orthostatic intolerance associated with an increased heart rate of at least 40 beats per minute, or an increased heart rate of 120 beats per minute in the first 10 minutes of upright position. They should not be showing hypotension, and the blood pressure might even elevate. And we certainly see extremity modeling, and we can see joint hypermobility as well. And you really need both the significant historical features and the heart rate changes for diagnosis. Oh, wait, greater than 40 beats per minute? So, for adults, it's greater than 30 beats per minute. And in 2012, Wolfgang Singer at the Mayo Clinic demonstrated that in normal adolescents who are asymptomatic, although a significant number of these patients after you go back were symptomatic, but if you did a tilt table test in normals, 42% of them had a increase in heart rate of at least 30 beats per minute on tilt. And so they determined that the 95th percentile for increased heart rate was 42 beats per minute. And so a bunch of folks got together and said, so we're going to use 40 beats per minute as the threshold for age 12 to 19 in 2015 and 2018. That was the accepted threshold. But that's with a tilt table test, and your results may vary with a standing test. A tilt table test is more provocative, it's less physiologic, and it is passive upright position as opposed to what's considered active upright standing. However, a 10-minute stand has not been validated. There have been a couple of studies that have come out both in adults and in children that demonstrate that the increase in heart rate on a 10-minute standing test is not as high as that of a tilt table test. And the other thing too is with the tilt table tests, there's variable protocols. You can tilt them from 65 to 80 degrees. It depends on how long. You measure a lot of stuff, and people can do all kinds of other tweaks with this, adding saline, adding isoproterenol to really induce syncope. I'm not a fan of doing a tilt table test because it causes patients to pass out a lot of times, and it can certainly cause a PoTS flare. And by the way, in patients diagnosed with a 10-minute stand, we published in 2019, there was really no statistical difference in symptomatology or symptom frequency in patients who had a heart rate increase of 30 to 39 beats per minute versus those who had a 40 or greater beat per minute increase. And we've actually seen similar findings in patients who have a 25 to 29 beat per minute increase. So, in the end, using heart rate as a threshold is probably not our best move, but that's what we got right now. What do we call them? Is it chronic orthostatic intolerance? Is it the same? Just don't know. So one quick thing, and that is typical orthostatic measurements where a physician would have the patient lay down, then sit, then measure it in the first minute standing is not the same as a 10-minute standing test. If patients have tachycardia in those findings and lightheadedness, we call that initial orthostatic hypotension. That typically resolves. We see that a lot in adolescents. I used to have it too. That's probably due to growth and hormonal changes. It's benign. We do see it in PoTS patients, but it is not PoTS. You need that persistent heart rate elevation and symptoms of orthostatic intolerance in that 10-minute stand or the tilt table test, either way. As far as laboratory studies in the evaluation of PoTS patients, I like to get an electrocardiogram, a 24-hour Holter monitor, and a lot of basic labs are typically done before they see me, but the ones that I like are thyroid function testing, a ferritin, which is your total body iron level, a morning cortisol level, and a vitamin D. So how do we treat these patients? Well, we use a combination of non-pharmacologic and pharmacologic interventions. My feeling is that the non-pharmacologic interventions are foundational, meaning those are the ones that we've got to do and that we build upon. And then we go from there. So first and foremost, as I tell my patients, is making sure that their tank is full of fluid, 80 to 120 ounces a day or more. In my long-term outcomes survey, I had some patients who drank as much as 2 gallons, 256 ounces of fluid a day, and lots of salt, 8 to 10 grams a day of sodium chloride. The folks in Calgary, Dr. Satish Raj and his team did a study a year or two ago where they looked at giving patients as much as 17 grams of sodium chloride a day. We do try to avoid routine IV fluids if we as much as possible. No skipping meals, no caffeine as it is a diuretic, good sleep hygiene. Get rid of those electronics before bedtime, please. Thank you very much. And get the lights down. And then elevating the head of the bed on a cinder block or risers about 6 to 8 inches allows you to sleep with your head above your kidneys, which causes your kidneys to hold on to salt and water overnight and reduce the symptoms of feeling worse in the morning when you wake up, at least for some patients. We also like to avoid triggers, prolonged standing and extreme heat. I recommend the use of a cooling vest, especially an evaporative cooling vest for my patients who have heat intolerance, and the use of compression garments. Historically, I would recommend using compression stockings that are waist to toe, giving 20 to 30 millimeters of mercury compression. They should be worn just while awake. I did have a patient who showed up wearing them for 24 hours a day for 7 days. And she came into my clinic and she said, my toes are numb. And I said, I'm not surprised. And there's variable success with them. They're hard to put on. They certainly they can make some abdominal compression and discomfort. It makes some patients really warm when they don't want to be. However, the other option is using an abdominal binder. And that is something that you wear while you're awake. It compresses the splanchnic circulation, where there has been research to show that PoTS patients pool their blood in those blood vessels in the abdomen, more so than in the extremities. And so using an abdominal binder squishes your belly, squishes the blood vessels, and forces the blood into your core circulation. And it's felt to work better than compression stockings. The Canada group, again, the Calgary group, published this about 3 years ago. And as I mentioned before, using exercise is really important for these patients. I referred to what is referred to the Levine protocol or the Dallas protocol. Dr. Benjamin Levine is an exercise physiologist at the University of Texas Southwestern in Dallas, so that's why I refer to it as the Dallas protocol. As I mentioned before, this is an exercise protocol that does aerobic activity as well as leg and core strengthening. It starts off recumbent, so not upright exercise. It starts off minimal, and it has 8 months of calendars. So it just guides you through every day of your life for the next 8 months. For patients who have joint hypermobility, I strongly recommend these patients be seen by a physical therapist to learn how to protect and stabilize their joints, as well as doing several other issues from a PT standpoint, which we can discuss later if you like. With the original Levine protocol, was a little bit hard for my patients to parse. And so I sat down with one of our physical therapists at the Children's Hospital of Philadelphia some years back and rewrote it. And so you can find it online at the Dysautonomia International. If you do an internet search for Dallas CHOP PoTS, you'll find it. But it's been modified for adolescent and young adult use. There are a lot of options from a medication standpoint that we can use for the management of PoTS as well. And I've published on that also. Fludrocortisone is a really helpful therapeutic addition. What it does is it works at the level of the kidneys to hold on to salt and water to keep your tank full. And the side effects are very infrequent. Midodrine is a peripheral vasoconstrictor. It causes the blood vessels at the edge of your body to squeeze, and that supports your blood pressure. One of the issues with midodrine is you have to take it every 4 hours on a 3 times a day. So that gets to be a little bit of an annoyance, but if it works and you tolerate it well, it's really very helpful medication also. For some patients who are doing well overall, but just have worsening lightheadedness or orthostatic intolerance with exercise, one of the tricks that I'll use is I'll have them take the midodrine 30 minutes prior to exercise for just that 4-hour window. And they don't have to take midodrine otherwise, but they can take it for that 4-hour window, and that often helps them get through it. The use of beta blockade or beta adrenergic receptor blockade, such as metoprolol, can be helpful for preventing headaches and the palpitations and tachycardia. There's another one called nebivolol. It doesn't cross the blood-brain barrier, so you don't get as much fatigue or potential for depression. However, lately I've been using much more low-dose propranolol, which the way it works is in high doses, beta blockers drop your blood pressure, which is totally what we don't want. In lower doses, though, what it does is it slows the heart rate down just enough to prolong the amount of time allotted to the heart to fill with blood. So if you have more time to fill the heart with blood, you have more blood to pump out, more blood to pump out, more blood to your brain, less lightheadedness. And really, my patients who also have panic attacks love it because their heart rate is gated, so they don't have their heart rate take off on them during panic events. And I'm sure a number of you have heard of ivabradine, which is a relatively new medication. It slows the heart rate down as well, but you don't get the hypotensive effects of beta blockers. It's very well tolerated, very few side effects. It remains on patent, so in the United States, at least, it's quite expensive, and of course, there's no generic. It's going to be on patent for another 2 years. So hopefully, in another 2 years, we'll see a generic. The use of DDAVP or arginine vasopressin is another medicine that's similar to Florinef in that it works at the level of the kidneys, but it only holds on to water, not salt. So one of the concerns is that it can cause hyponatremia, low sodium in the bloodstream. So I mandate that patients take salt supplements during the use of desmopressin or DDABP. Pyridostigmine was historically published as a medication that can help, quote unquote, with the symptoms of POTS. And I started using it to try to help reduce lightheadedness and blood pressure or drops and tachycardia and that kind of thing. But what I've actually found is it works phenomenally from a GI standpoint for patients who have nausea, constipation, early satiety, slow GI motility. There are some data to suggest that it may improve the systemic blood flow return to the heart, and so it could help with orthostatic intolerance, but I use it from a GI standpoint and have had very good results with it. Some other therapies for gastrointestinal dysmotility, abnormal GI motility, include erythromycin, prucalopride, and melanoxidil. For fatigue and cognitive dysfunction or brain fog, I've had very good results using stimulants. In the United States, at least, these are considered controlled substances, which means a limited amount can be given out, and it's controlled how these are prescribed. I usually start with methylphenidate. It's inexpensive. It works really well for patients, and they've really found that it's been life-changing. We'll show those data in a little bit. Mixed amphetamine salts can also be helpful as well. Lisdexamphetamine and dexmethylphenidate have been beneficial for patients also. Atomoxetine has had fair success in the use of fatigue and brain fog. It's not nearly as good as the stimulants, but in a small group of patients, I'd say probably about 10 to 15%, it does work. The nice thing about it is it's not a controlled substance in the United States. And then modafinil and armodafinil are medications that are used in patients who have idiopathic hypersomnia or sleep phase disorder or those kind of things. And it is also a controlled substance, works very well on fatigue, but doesn't necessarily work on brain fog particularly well. But what it does is if you take a stimulant in concert with it, you need a much lower dose of that stimulant. For nausea, I've had very good success using ondansetron. Occasionally I'll have to use scopolamine, which is the seasickness patch that goes behind your ear. For nausea, you can also use it for hyperhidrosis or significantly increased sweating. Also for the increased sweating, aluminum chloride hexahydrate and glycopyrrolate. Very rarely I've had patients who started out as POTS with tachycardia and all of a sudden flipped to having severe bradycardia. And so I've used glycopyrrolate for this as well. For sleep, historically, I used to use melatonin, but there are increasing data to suggest that the use of melatonin in children and adolescents is probably not our best move, that there are some concerns with its use. Therefore, I have been using clonidine, which is quite well tolerated. Trazodone also works, although there can be a little bit of sleep hangover. Remeron as well, or excuse me, mirtazapine as well can work. And then zolpidem and ezapicolone are medications that can be used that I only use them for 2 weeks. And what I use them for is when I have patients who have their nights and days just totally flipped. And if that's the case, what I'll do is I'll just hit them hard with zolpidem or ezapicolone and reset their sleep schedule for 2 weeks. And often that can make a good difference for them. For chronic pain, the use of pregabalin can be really helpful. Also duloxetine, which is a combination of selective serotonin and norepinephrine reuptake inhibitor. I'm sure a number of you have heard of low-dose naltrexone. Naltrexone is the long-acting oral version of naloxone, which is an opioid antagonist. It comes in a 50 milligram tablet. However, very low doses can block the release of inflammatory mediators. So it can be used for chronic pain from that standpoint. Other medications that I've used as well, cyproheptadine is an antihistamine that has multiple effects. It can make you sleepy, so it can help with insomnia. It can help prevent migraines. It increases gastric accommodation, so it can reduce nausea and it can improve appetite. One of the big side effects that we can see with this is unwanted weight gains. We have to kind of pay attention from that standpoint. Verapamil is another medication that can be used for headache prophylaxis. And speaking of headache prophylaxis, so when we talk about migraines specifically, there's two ways to treat migraines. Either abortive therapy, meaning you take a medication to make it go away, or you take a medication from a prophylaxis standpoint to prevent it. And there's several different things that can be used for prophylaxis, including magnesium plus riboflavin, coenzyme Q10, amitriptyline, topiramate, CGRP inhibitors, botulinum toxin, and nerve block injections. Other injectable type of therapies include octreotide, which decreases splanchnic blood flow and almost works like an injectable abdominal binder, if you will. And normal saline infusion, again, as I mentioned before, we try to avoid this if possible. Erythropoietin has also been fairly helpful for patients who just don't respond to medication therapy. So, patients do often need polypharmacy, and with the goal of improving their symptoms, so it allows them to be able to exercise, and then you wean them down as tolerated. And I tell my patients, as your physician, my job is not to shove medicine down your throat, it's to give you options. But I tell them that the corollary to that is, if the symptoms are bad enough that it's preventing you from doing your activities of daily living, then let's consider doing something about it. That said, and this is one of the hardest things in adolescence, is getting adolescents to take ownership of their own care is so important. If I can't take care of everything, then I will refer patients out. They have persistent GI motility issues. They have bladder issues to urology, for example, for biofeedback. If I'm concerned about a mitochondrial disorder, I'll have them seen in our metabolic clinic, or in the metabolic clinic or the mitochondrial clinic. Patients might need to be seen by neurology for persistent headaches. If there's a concern for craniocervical instability, I'll have them see neurosurgery and also physical therapy as well. For neuromuscular clinic, for small fiber neuropathy, connective tissue disorders clinic if needed, behavioral health for managing and coping with chronic disease, and that's the patient and the family. If there's a concern about persistent mast cell activation syndrome, I will have them see an allergist immunologist, and then also see interventional radiology and general surgery if there's a concern for median arcuate ligament syndrome. So are there emergencies? Occasionally, and certainly patients need acute IV hydration. They might need a headache protocol. They might have other persistent GI issues. Hospital admission is uncommon, typically for prolonged GI or neurologic management or uncontrolled hypertension, psychiatric problems. We actually published, let's see, there we go. We actually published in last year and found that 30% of patients, PoTS patients, as compared to controls in the emergency department, had a GI problem. About that same number had a headache issue. Interestingly enough, more control patients had concerns for autonomic issues. And then look down at the bottom. Only 2.5% of PoTS patients were seen in the emergency department for psychiatric symptoms, whereas 9.4% of patients were seen, actually, here we go, were seen for, there we go, were seen for psychiatric concerns. Very interesting, right? So this is almost 300 patients who are age and sex matched with controls over 3 years. So very significant differences here. Don't forget school, and patients often need accommodations, 2 sets of books, one for school, one for home, an elevator key, extra time between classes and for tests, maybe need a friend to walk with, being able to have access to water and salty snacks, a place to self-limit, and a place to chill out if needed. Also, partial day school, virtual school, and homebound might be needed as well. Limiting PE or replacing it with the Dallas Protocol has been used as well. For in the United States, taking the SAT or the ACT, which are the college admission testing, they might need accommodations for that. For college or university, having a first floor dorm room so they don't have to do stairs, air conditioning, private bathroom, the ability to tape record lectures. Interestingly, I find that college is often easier for patients because the patients have more self-awareness and are able to own the disease. And they have more recovery time between classes. So let's talk about a little bit of research. So first off, we had when I was at the Children's Hospital of Philadelphia, we saw I had 722 patients with the PoTS diagnosis as of June of 2016. 708 of them were age 18 and under. It was the largest known clinical pediatric PoTS database in the United States. And so we published in 2018 a retrospective review of these data. So here we go. First off, race and ethnicity. Now we're seeing that 94% of patients were Caucasian or white with very low Black, African American, or Asian and Hispanic numbers. And these data have been seen in other locations, but I think there's a combination of, there's a concern for access, and there's a concern for cultural issues, and there's a concern also that the medical establishment has significant bias against people of color. So I'm not 100% convinced that these data are totally correct. Their age of presentation, the median age of presentation was 15.5 years, although I've seen patients who are down to age 6 with what I feel is PoTS. A 3.5 to 1 female to male ratio. The age of symptom onset was about 12 years. The duration of symptoms prior to diagnosis was about 3 years. For patients who had triggers, about a quarter of them had an infection, 11% had a concussion, and 3% had surgery or non-trauma. For those who had an infection, this is pre-COVID. So upper respiratory tract infection, Epstein-Barr virus, gastroenteritis, and Lyme disease were the top players in this field. For patients who had joint hypermobility, in that series, 57% had joint hypermobility, including 22% having hypermobile Ehlers-Danlos syndrome and 35% having joint hypermobility not meeting those criteria. Subsequently, in 2021, our study showed that nearly 62% demonstrated hypermobility, with about 23% having hypermobile EDS and 39% having hypermobility spectrum disorder. 5% of patients had an inflammatory disorder, including celiac disease, Crohn's disease, thyroiditis, eosinophilic esophagitis, diabetes. With regard to their presenting symptoms, the top 6 initial complaints were dizziness, headache, fatigue, abdominal pain, syncope, and nausea. So as you can see, neurologic, cardiovascular, gastrointestinal. Subsequent symptoms, 2/3 of patients had at least 10 symptoms, half of patients had at least 14 symptoms, and 30% of patients reported at least 26 symptoms. Here are the top 14 symptoms that we see, and again, broken out across cardiovascular, neurologic, and GI symptomatology. If the patient had joint hypermobility, the female to male ratio was higher, their duration of symptoms was higher, and the median age of symptom onset was lower. We then looked at medication efficacy, in which the patient had to have that same prescription at the same dose for 5 times in a row or more, which is a very high bar. And so we found that effectiveness or efficacy ranged from 39 to 53% for dizziness, headache, nausea, dysmotility, pain, and insomnia. But look at fatigue and brain fog, 69% efficacy. And most patients needed, anywhere from 1 to 2 therapies to finally get it right. When we look at family members, and I referred to this a little bit before in 2020, in 579 PoTS patients, other family members had either PoTS, 14%, dizziness and syncope, 17%, 31%, therefore had one of the above. 20% of PoTS patients had joint hypermobility, had a family member with joint hypermobility. If they were also hypermobile, 26% had a hypermobile family member, and 45% of PoTS patients had a family member with an autoimmune disorder. Lastly, our long-term outcomes survey, it's one of the largest and longest outcomes studies. The average age of patients was 21.8 years. If you want to read it yourself, it is available open access online. It covered multiple issues: diagnosis, treatment and outcomes, educational, employment, and social outcomes. That part is not yet published, and the gynecologic associations have not yet been published as well. But we found that female patients had more symptoms than males, at least 10 and at least 15 symptoms, more so, had worse symptoms than male, more pain, and a worse GI score, and had a longer symptom duration than males, still needing salt, water, and exercise to control their symptoms. But nearly everyone was still symptomatic, and 99% of patients, as I mentioned before, were still symptomatic in the month prior to completing the survey, meaning that PoTS doesn't go away. They found that the most beneficial interventions were medications, fluid salt intake, and increased exercise. The quality of life demonstrated a moderate decrease in both pediatric and adult patients. Over half of patients had a trigger, as we talked about before: infection, injury, surgery, or pubertal changes. Prior to diagnosis, almost 2/3 of patients were told the symptoms were psychiatric. Over half were told that their symptoms were in their head, and 3/4 of them had seen a doctor who'd never even heard of PoTS before. After their diagnosis, still almost a half of patients were told their symptoms were psychiatric, and 32% were told their symptoms were in their head, with 46% currently being treated for a comorbid psychiatric disorder. As far as education, employment, and social issues, 97% of patients missed school because of PoTS, and almost half of them missed over 100 days. 70% of them dropped out of sports, over half dropped out of extracurricular activities. But interestingly enough, by age 21, almost 100% of them had either their high school diploma or their graduate equivalency diploma or degree. 80% attended college or university, and 91% of them either graduated or were still attending, and 19% went to graduate school. A number of my patients have actually gone on to medical school, nursing school, physical therapy school. Pretty cool. From an employment standpoint, around 60% were employed in the last 3 months, 45% of them working at least 31 hours a week, and a third of them would have worked more if not for their health issues. That said, 2/3 of them missed work because of their PoTS, with about half of them missing over a week. And almost half of them modified their job because of their PoTS. 63% with a workplace modification, and 3/4 with a reduced schedule. From a social standpoint, 60% of patients lost friends due to PoTS, a fifth lost a serious relationship, and 70% lived in with their parents, including 37% who had moved out and then moved back in. From a gynecologic standpoint, we did not see evidence of abnormal uterine bleeding, but our patient population was a younger and older patient population did show abnormal uterine bleeding, heavy periods, prolonged periods. As mentioned before, 72% of patients had worsening symptoms perimenstrually, with nearly all of them having them either prior to or during their menses. 2/3 of them used hormonal contraception, with half of them showing somewhat or much better perimenstrual PoTS symptom reduction. Anecdotally, we see a low estrogen containing oral contraceptive or intrauterine device has been really helpful. So the bottom line is PoTS is not fatal. It's just debilitating, annoying, and anxiety and depression provoking. So the patients and families need validation, encouragement to continue working with therapeutic options, fluid salt intake and exercise, and identification and management of comorbidities. And I think we're good. Let's talk.
Thank you so much. That was absolutely fascinating, and can't believe how much you managed to cover. So thank you very much indeed. Leslie, shall I hand over to you to go through the questions? There's lots and lots that have come in, so we can get cracking.
Yeah, I'd just like to add my thanks as well for giving up your time and for such an excellent overview. Yeah, we've had loads of questions come in. So the first one is, can you say a little bit about the link with COVID-19 infection and PoTS?
Yeah. So prior to 2020, prior to the pandemic, the estimates, at least in the United States, was that anywhere from 1 to 3 million people were affected with PoTS. And post-pandemic or post-onset of the pandemic, we think that in the United States, at least anywhere from 3 to 6 million people are affected with PoTS. And so, you know, the SARS-CoV-2 virus probably causes PoTS. It may cause it, certainly causes PoTS. It may cause it either because of the usual way, in that it's a post-infectious mechanism. It may cause it because of the microclots that it creates, the little teeny tiny blood clots it creates, which go to the heart, the kidneys, the lungs, the brain. Or there might be viral persistence, and we certainly know that viral persistence occurs and in the setting of COVID-19, and so that might be causing, but we don't know. There's a lot we don't know about this virus. This virus is just crazy new and different.
Okay, next question. Is there a link that you know of between PoTS and epilepsy?
No. Straight up, no. I think yeah, just that I have not seen. I have seen there may be a link with neurodivergence, right? So attention deficit hyperactivity disorder, autistic spectrum disorder, but not so much with epilepsy directly. Yeah.
Okay. Where can you find compression for a very tall, slim 12-year-old?
Yeah. So, so what I'm going to do is I'm actually going to recommend an abdominal binder, right? So, because that's what I end up recommending for my patients. And am I allowed to say brand names?
Go on, go for it.
Sure. Okay. So for a not so slim patient, I usually recommend one by a company called Incrediwear. It sort of sounds like incredible, but it's Incrediwear, and it's called their body sleeve. However, for patients who are really slim or really small, and I cannot believe I'm saying this, the Kim Kardashian Skims waist trainer makes very small sizes, and those have actually worked quite well for my patients who need sort of a smaller version.
That's really helpful, thank you. And can you say something about your success rate with compression in younger people, and sort of balance that out with the challenges of actually getting it on and tolerating it?
Yeah, no, it's a great question. And you know, I don't have numbers for this. And I think the thing to keep in mind, and I really didn't talk about this in my talk, but what works for one patient doesn't work necessarily for another. There's so much variability in how patients respond. And so I will have some patients do the elevated head of the bed thing that we talked about. I'll have some patients do the compressions, the abdominal compression thing, for example. And, you know, they'll do it. And some of them are like, wow, I totally notice a difference. And others are just sort of like, eh. Or what they'll say is, especially with abdominal compression, they'll say, you know, I still it makes my stomach hurt. It causes me to feel hot. I have sensory issues with it. So I can't use it. I find the abdominal binders are at least somewhat better tolerated than compression stockings. And I'm okay with that because they tend to work better. I think there's less pooling with compression stockings. For those folks that do want to use compression stockings, if they, I have a smaller number of patients who have cold intolerance, and so they really, really appreciate using compression stockings. One of the little tips and tricks that I picked up from my patients teach me a ton. And one of the tips and tricks I picked up from one of my patients is if you use the dish gloves, like the rubber dish gloves in the United States, the brand is Playtex, but I, don't know in the UK. It'll help you get a better grip to help apply the compression stockings and to put them on. And so, normally it's a 15-minute wrestling match to put on the compression stockings, and this can significantly reduce that duration. In the bigger picture, if I have a patient who tries to use an abdominal binder and has either persistent nausea or persistent abdominal pain, one of the things that I do is I approach and I'm like, well, what am I missing? What am I not treating that needs to be then to help reduce that nausea or reduce that abdominal pain? Is mast cell activation syndrome not being treated? Is constipation or dysmotility not adequately treated? And if we can treat that, then we can try again with the abdominal binder.
Which of the I'm not sure if you can answer this one. And which of the medications that you discussed are available in the UK for under 18s?
Uh-huh.
Do you want me to answer that one?
Would you? Yeah, I have no clue. I would assume that nearly everything that I mentioned is probably available.
Yeah, pretty much all of them are available, but every medication that's used in PoTS is unlicensed for use in PoTS in the UK as well. And so you'll find that there's a lot of reluctance to prescribe. And so certainly GPs and cardiologists and neurologists and pediatricians will often prescribe off license the ones that they're more familiar with, but they can often be very reluctant to prescribe the ones that they're not used to using generally in their other practice. I often find as well that they're more likely, for example, if it's a cardiologist you'll see, they'll often prescribe more the cardiology drugs, and if it's a neurologist they'll often prescribe the neurology drugs, and then the pediatricians will often prescribe the ones that tend to be used in children in their other practice.
No question. No question. And we see the same thing in the States as well.
How long can you stay on, the example that was given by this particular person was ivabradine and midodrine?
As best as I can tell, I don't think that there's necessarily a limit as to how long therapy can be used with them. Certainly in adults, ivabradine is used in patients who have chronic heart failure, and it's used chronically for those patients. For midodrine, one of the things is you want there to be some physiologic reset, which is why you only take it 3 times a day. And then you get sort of this reset overnight. There's a metabolite that can build up in the system that you don't want to build up. So that's why you only take it 3 times a day. But if you do it that way, you can take it indefinitely, as far as I can tell.
Can I just add a little comment in there about obviously children grow into adults, and certain drugs that are used in PoTS are contraindicated in pregnancy. So it might be, you'll either have to investigate contraception or stop it if you're planning to become pregnant. And ivabradine is one of the ones that is thought to be the biggest culprit in terms of causing harm to a future fetus.
Thank you.
There are some concerns about midodrine as well.
Yeah, thank you. Yeah, I don't take care of adults with pregnancy. And pregnancy in the setting of PoTS is an entirely separate talk, honestly.
Absolutely, yeah. You mentioned concerns about melatonin. So somebody's asking, can you say a little bit more about these concerns, and are you able to direct to any journal papers that they might be able
to? So the short answer is I can't. I read about this about 6 to 9 months ago, and I would have to go back. I apologize. I'd have to go back and learn what the specific concerns are. I think in general, being that it is a supplement, Just sort of the general issues that go along with supplements are, at least in the United States, apply in that they're not overseen by the Food and Drug Administration, and therefore content is not assured, supply chain is not assured, dosing is not assured. The research for most supplements is poor. Melatonin is one of the few that actually has decent research for that. Specifically, though, I vaguely recall that at minimum, using exogenous melatonin suppresses your own body's ability to make melatonin, so you can get dependent upon it. And that's certainly an issue. But I think there's some other issues that went along with that, and I don't quite recall what they are, and I apologize.
No worries. Can you say a little bit about your approach to people with PoTS who also have either long COVID or ME/CSF and experience quite marked post-exertional symptoms?
Yeah, so long COVID is felt to cause 3 entities, right? So PoTS, mast cell activation syndrome, and ME/CFS, myalgic encephalomyelitis chronic fatigue syndrome, or combinations thereof. And with ME/CFS, that gets to be an issue because we have to be careful. So the diagnostic criteria are a little squishy. There's been definitely some disagreement amongst amongst those folks there. And there's also this concern about, there is this issue of post-exertional malaise. And I have to be honest, I don't know how patients with ME/CFS are, if they are treated, for example, with, say, stimulants and blood pressure supporting medications, whether that post-exertional malaise still exists, still persists afterwards. I don't know the answer to that. I find that a lot of people who think they have ME/CFS, once they start, just because they're so wiped out because of their PoTS, once they actually start getting better control of their symptoms, do fine with exercise, and they don't have the PEM that they thought they were going to have. I think there is a subclass of patients or subgroup of patients who do. In other words, their PEM is so drastic that even with appropriate therapy, they're wiped out for like a day, 2 days, 3 days kind of thing. And there's some recent research to suggest that in ME/CFS, there is a protein that is made by the mitochondria that is screwed up. And that research came out within the last 1 to 2 months, and it was fascinating. And I would really love to see more research along that lines, because that would suggest that there is that these patients are distinguishable, right, from ostensibly from PoTS patients. So, yeah.
Thank you. Can you say a little bit about wheelchair use in PoTS?
It's a thing. So I mean, so are wheelchairs used? Sure, of course, wheelchairs, if there is a patient, there are several reasons why wheelchairs could be used in PoTS patients. One is severe orthostatic intolerance. 2 is severe joint hypermobility, to the tune that these patients have awful arthritis, right? And there may be other reasons as well that I'm not taking into consideration. Ideally, what I recommend, if a patient asks me about a wheelchair, if they need it early on, so early on, if they are exceedingly debilitated, and I've certainly seen patients like this where they need, if they're going a long distance, they're going from a parking lot through a store, a parking lot to a movie, or to a long distance. I think it's not unreasonable to use a wheelchair, but my hope is that we can suppress their symptoms, and allow them to be more functional so that they don't have to use a wheelchair. And I've absolutely had patients who start out with, as needed wheelchair use and have progressed to not needing it at all.
Next question. Can ivabradine cause fuzzy vision? And
one of the few but notable side effects of ivabradine is what's called the creation of phosphenes. Phosphenes are sort of this yellowish haze around objects that you can see. It's sort of like Van Gogh's Starry Night. And although some people thought that was the Jackson toxicity, but yeah, so ivabradine can do that. As far as fuzzy vision, so there's two ways that I would characterize that. One is if it was phosphenes, if that was just a version of phosphenes. The second way, though, is if you slow down the heart rate too much with either a beta blocker or with ivabradine, you can actually drop your cardiac output further. And so if your resting heart rate is too slow, that may cause blurry vision, tunnel vision, and worsening lightheadedness as well. You don't get the tachycardia, but you might have worsening orthostatic intolerance.
Thank you. Are bladder issues seen in adolescents with PoTS?
I'm sorry, are what issues?
Bladder issues.
Bladder issues. Yes, not commonly that I've seen, but yeah, usually difficulty with urinary frequency, urinary urgency, that kind of thing. And there's two main issues that I see with that. One is it could be just straight autonomic. And what I recommend is a urology evaluation for those patients. And they may benefit from using biofeedback to help improve their bladder capacity. However, the other thing that we see in PoTS patients with bladder issues is interstitial cystitis. And interstitial cystitis is probably actually in reality a version of mast cell activation syndrome. And in other words, if you do a biopsy of a patient of a patient's bladder who has interstitial cystitis, you see a ton of mast cells. So it's one of the things that I'll treat from an MCAS standpoint, and try to help improve it from that way.
Thank you. Well, I think we've run over quite a bit, so thank you very much for giving up your extra time. And
yeah, I'm fine. If you want to go through more questions, I'm good. Whatever you like.
Are you sure? What about you, Jo? Are you okay?
Yeah, I'm good for about another 5 minutes. Yeah.
Okay. Brilliant. So which consultant should oversee children with PoTS, cardiology or neurology?
The answer is it depends, because the problem is that, at least in the United States, we see cardiologists, we see neurologists, we see gastroenterologists, we see pediatricians who know how to take care of PoTS. So it's not the specialist, it's the specialist's knowledge. And I think there's wide variability in the way these providers take care of these patients too. So for example, there are some cardiologists who will be like, I will just take care of the cardiac stuff. I won't take care of the neurology stuff, and I won't take care of the GI stuff. And then there's others like me who just take everything on. So it's really more about finding somebody who is familiar with PoTS, and it's not just finding someone. We sort of talked about this before we came on. A lot of cardiologists, a lot of gastroenterologists, a lot of neurologists are not interested, just not interested in taking care of PoTS patients. It's a significant prolonged workup. There's a lot of symptoms. They weren't taught about it in medical school or residency. And it's not what they trained, quote unquote, not what we trained for. So, it's finding someone who knows. And so it's, if you have a registry of PoTS providers in the country, that would actually be really, that'd be really helpful to sort of find folks who, who freely say, yeah, this is what I do. This is my gig.
The next question is, how ill do you need to be to get a specialist referral? I mean, if you present to your family doctor, your GP, how much would you expect them to do? And at what point should you ask or expect to be referred on to a specialist?
It's a hard question, because culturally, there may be differences in the UK versus the United States, so I can't address how that would necessarily work. Again, I think if it's more how the patient is doing. If the patient is, if the primary care provider, the general practitioner, has a good comfort level, seems to be relatively knowledgeable, seems to be interested in learning and helping, then that's where I would hang out with that provider. But I think if the provider is dismissive, is sort of saying that this is due to anxiety, if they're gaslighting the patient, I would kick that provider to the curb so quickly and find someone else.
Yeah, one of the problems we hear is that the GPs are the gatekeepers to secondary care, and so if they're uninterested, it sometimes becomes quite difficult for the patients to then get a referral onto somebody in secondary care, and that's the sort of ongoing challenge that we have here.
One of the things that patients have increasingly been doing is coming in with the results of a 10-minute standing test that they've done on their own. So they'll lie down for 5 minutes, measure their heart rate, stand for 10 minutes, measure their heart rate once a minute, and their standing should be completely standing, not leaning on anything, minimal stimulation, no phones, no TV, no talking, no nothing, just standing boringly still, and measuring their heart rate, coming in and saying, here are my data on a 10-minute standing test. Here's a review article on PoTS. Knock yourself out. What can we do about this?
We've actually got a one-page leaflet on our website that patients can print off and take into their GP, and it sort of explains what it is and the basic things that we can do. So we hope that that's
and that's helpful. I think, unfortunately, I think that's a good start. I think that there are a lot of doctors, because doctors have a number of them have insanely big egos, and they don't respond to anything except a research article.
Yeah, that's a really good point. And then some of them won't read anything that's more than one page of A4. So,
and that's okay, but as long as they recognize that it's a research article, and they might look at it later. I mean, but to your point from before, if they're exceedingly disinterested, they're exceedingly disinterested, and that's just how it's going to be.
So last question, I think. Is it common to be initially diagnosed with CFS or ME/CFS and then eventually PoTS?
So I learned something in the last few months, that ostensibly you can be co-diagnosed with PoTS and ME/CFS. I was not aware of that. I thought they were sort of, based on their descriptions, they sound kind of mutually exclusive. And in my heart of hearts, I still think they're mutually exclusive. Do I think you can be diagnosed with ME/CFS and then have it transition to being PoTS? Sure. We know that ME/CFS is associated with orthostatic intolerance. It's associated with fatigue. It's associated with brain fog. It's associated with a number of autonomic dysautonomic type symptoms. And I think there's a lot of poor understanding of the diagnostic criteria for ME/CFS and what differentiates it from PoTS and that kind of thing. And so it may just well have been that the initial provider made a wrong diagnosis, and someone else with more understanding said, I think this is probably more PoTS than ME/CFS.